Hello friends, today we will discuss about an important electrolyte, that is potassium. The normal value of potassium is around 4 milliequivalents per liter and the normal range is between 3.5 to 4.5 milliequivalents per liter. If serum potassium drops to less than 3, then we call it as a hypokalemia. And we may get ECG changes like ST segment depression, prolonged PR interval and prominent U wave if the potassium drops significantly or if the drop is acute. We need to see reasons for hypokalemia, whether the patient is on potassium lowering drugs like furosemide or torsemide, insulin infusions, whether the patient is getting salbutamol nebulizations, whether the patient is getting sodium bicarbonate. So we need to stop all these drugs because they may cause either caloresis or transcellular shift causing hypokalemia. We need to treat hypokalemia. If it is mild, then we can use oral Kesol syrup, and if it is moderate to severe, then we can give IV KCl infusion. If patient has a peripheral line, then we can give up to 20 milliequivalents per liter of potassium in 1 hour. And if patient has a central line, then we can give up to 40 milliequivalents of potassium in 1 hour. In cases of resistant hypokalemia, we can give injection magnesium sulfate. Now we will discuss about hyperkalemia. If the potassium value rises to more than 5.5, then we call it as a hyperkalemia. And it also shows ECG changes like tall peak T wave, prolonged PR interval, ST segment depression, flattened or absent P wave, ventricular premature complexes, sine wave pattern, and in severe hyperkalemia more than 8 milliequivalent per liter, we may get ventricular fibrillation also. So it's a medical emergency. So initial drug of choice in severe hyperkalemia is calcium gluconate because it stabilizes the cardiac membrane and prevents occurrence of cardiac arrhythmias. The dose of the calcium gluconate is 10% of calcium gluconate 10 ml over 10 minutes. And we can repeat calcium gluconate after 10 minutes if the ECG changes are not reverted. Other drugs like sodium bicarbonate 25 ml we can give, then GI drip, that is glucose insulin drip, in which we use 10 units of insulin in 100 ml of 25% dextrose infusion. Then we can give salbutamol nebulizations and we can repeat every 10 minutes up to 2 to 3 nebulizations. Then we can give K-bind, that is potassium binder, 30 grams orally. We can also use loop diuretic like Lasix or Ditor. And in cases of severe hyperkalemia, we need hemodialysis for rapid correction of hyperkalemia. As a dietary advice, we should ask patient not to consume potassium-rich food, citrus fruits which are rich in potassium, coconut water, and also need to check whether the patient is on potassium sparing diuretic like spironolactone, and we need to stop that also. Thank you.